Hi everyone, welcome to this interactive unfolding case study. In this episode, you'll step into the nurse's role as we follow a realistic patient scenario from a primary care visit to urgent care. And you'll be challenged to think clinically, prioritize care, and apply nursing judgment. Let's start. The first section of our scenario here is about a 74-year-old male who presents to a primary care clinic with 4 months of excessive daytime sleepiness, cognitive fogginess, and irritability, with the following vital signs: with a blood pressure of 150/94, heart rate 80, respirations 20, temperature 98.4 degrees Fahrenheit, oxygen saturation of 92% on room air. He came in due to chief complaints of excessive daytime sleepiness and cognitive fogginess for 4 months, and the wife reports loud snoring, gasping during sleep, irritability, and falling asleep during conversations. His height is 5 feet and 10 inches, weight of 265 pounds, 120.5 kilograms, with a BMI of 38.1 kilos, and has allergies to penicillin and takes lisinopril 10 milligrams daily for hypertension. His history and physical included a history of hypertension, which is partially controlled, obesity, pre-diabetes with A1C of 6.2% last year. He is a part-time accountant with 20-pack year smoking history. He quit 10 years ago, no alcohol, drug use. His father had a stroke at age 70 and mother has type 2 diabetes. He is obese, drowsy, and has crowded oropharynx, and that means that there's that class 4 myelopathy. He has elongated uvula with a circumference in the neck of 18 inches. Respiratory assessment said something about scattered rhonchi, clears with cough. And for cardiovascular, it said regular rhythm, as for Gallup noted. He has trace ankle edema. Now let's look into the healthcare provider orders for day 1. So the following are entered: polysomnography, ECG, fasting glucose, lipid panel, A1C, and complete blood count. Now we have the task for you. It said on day 1, the nurse evaluates the patient's presentation to differentiate the presenting problem from other conditions. Drag from word choices to complete the sentence. Here's the phrase: the client's presentation suggests blank rather than blank due to blank and blank. Now, for you to answer this question, here are the word choices: chronic heart failure, loud snoring, peripheral edema, obstructive sleep apnea, crowded oropharynx, as for Gallup, excessive daytime sleepiness, and orthopnea. Now, to answer this question, I need you to start pulling the clues from day 1 visit, especially the symptoms reported by the patient and the spouse. So I want you to think about which condition those findings best support. Is it about a breathing disorder or a heart condition? And make sure you use your clinical judgment to link those specific findings to either airway problem or cardiovascular dysfunction. And make sure you choose the words that clearly reflect the most likely diagnosis based on the anatomy, the sleep behavior, and presenting symptoms. Now let's fill in the blanks. The answer for the first blank is obstructive sleep apnea. It's because of the loud snoring, there's daytime sleepiness, and crowded airway. This is a combination which is a textbook obstructive sleep apnea. Again, the person snores loudly during bedtime, is always sleepy during the day, and has a narrowed throat. There is what we call as crowded oropharynx, or the myelopathy class 4. That means their airway is likely collapsing during sleep. It blocks the airflow and it leads to poor oxygenation. So these are not heart failure symptoms, and that's why the answer to the second blank is rather than chronic heart failure, because the presenting symptoms are all about sleep and breathing problems, not about fluid overload or cardiac strain. Now, the next part of the statement here, it said due to blank and blank. So we are actually associating this with the manifestations, right? So one of those is loud snoring and the other is crowded oropharynx. So the loud snoring that they're complaining about is a dead giveaway for the obstructive sleep apnea. And this happens when the soft tissues in the throat vibrate as the air tries to pass through a narrowed airway. This is a classic sign for obstructive sleep apnea, and this is not something you'd expect from heart failure alone. Now, for the crowded oropharynx, whenever there is a high Mallampati score, which is class 4, I want you to go back and look into the medical record. This means that the patient can barely see the back, or they can barely see it. If they're looking into the mirror, they can barely see the back of the throat when they open their mouth. And this is a structural clue that the airway is too narrow. So this is going to put them at a major risk for obstructive sleep apnea. Again, this has nothing to do with heart failure. That's a circulatory issue. All right. So that's why we are picking all those words right there. Now let's look into the other word choices such as peripheral edema. Why are we not selecting this one? Even though it said that the patient had trace ankle edema, well, this is also associated with heart failure, right? Because we will also see some buildup of fluid in the lower extremities, especially when a patient has right-sided heart failure. Even though it's possible for long-standing obstructive sleep apnea to eventually cause mild fluid retention, especially when they develop that hypertension, pulmonary hypertension. But this is not a primary sign of obstructive sleep apnea. This is a clue that will fit better with cardiac dysfunction. Now, looking into the S4 gallop, this is something that you can hear whenever there is stiffness in one of the heart valves. And this can happen whenever there is a long-standing hypertension or heart failure. And this one doesn't come from obstructive sleep apnea, which deals more with upper airway blockage, not cardiac stiffness. Now, if you selected excessive daytime sleepiness, yes, this is common in obstructive sleep apnea, but it's non-specific. There are many conditions that can make a person sleepy, especially during the daytime. It could be heart failure, it could be depression, or even poor sleep hygiene. So while this one adds to the picture, it's not a strong enough clue on its own. Lastly, we have orthopnea. This is something that can happen when a person cannot breathe when lying flat, which is a classic sign for heart failure, but not for obstructive sleep apnea. And this is something that is caused by fluid shifting into the lungs when the person reclines. And since this wasn't a part of the pattern, the patient's complaint, it doesn't support the obstructive sleep apnea and would actually make you think more about heart failure. So we'll get rid of that one as well. So here, focus on the patterns of obstructive sleep apnea, about airway obstruction during sleep. Again, this is not a problem about the heart pumping. So you got to look for those symptoms that clearly match one condition over the other. And you need to stay away from vague or overlapping symptoms unless they're paired with more specific ones. All right, let's get into our next test item, number 2. We have a bow tie this time. It said, on day 15, the nurse suspects an obstructive sleep apnea related complication during an urgent care visit. So let's go through the nurse's progress notes. Looks like we already tackled day 1, 8:30 in the morning. So let's go right ahead into day 7, 9 in the morning. It said, polysomnography, apnea, hypopnea 40, which is severe OSA, pulmonology consult, CPAP prescribed, a 10 centimeter water, patient hesitant due to claustrophobia, blood pressure 152/96, oxygen saturation of 93%, educated on CPAP. On day 14, 10 o'clock in the morning, at the sleep clinic, it said about CPAP used 4 hours per night, reports mask discomfort, nasal congestion, apnea, hypopnea, index 15, blood pressure 158/98, oxygen saturation 94%, wife notes less snoring, persistent fatigue, nutritionist referral. On day 15 at 1400 hours, at the urgent care, it said dyspnea on exertion, chest pressure after stairs, blood pressure 165/100, heart rate 90, oxygen saturation of 90%, EKG sinus rhythm, no acute changes, suspect obstructive sleep apnea related cardiac strain, provider notified. Now let's go into the healthcare provider orders. On day 1, it said about polysomnography, ECG, fasting glucose, lipid panel, A1C, and there is a pulmonology consult for obstructive sleep apnea, cardiology for hypertension, and CPAP order with a setting of 10 centimeters water, continued lisinopril, 10 milligrams daily. And for lifestyle, we have an order for weight loss program, dietary counseling, and exercise plan. And we have the results for the following lab tests: hemoglobin 14, fasting glucose 112, A1C 6.3, total cholesterol 230, polysomnography, apnea, hypopnea index of 40, and ECG showing sinus rhythm S4. And here we have our bow tie diagram. So the following options are for the potential complications. It said about chronic kidney disease, major depressive episode, hypothyroid crises, acute myocardial infarction, and pulmonary hypertension. So here, when you are tasked to finish a bow tie diagram, I want you to first look closely at the urgent care visit details on day 15 and look for those complications. And by using cue recognition to spot those cardiopulmonary strain, and also consider how partial CPAP adherence might have contributed to these. And then you're going to select those 2 assessment findings and 2 nursing actions that directly align with that complication. And make sure that you stick with interventions that fall within nursing scope and support the patient's immediate needs. Now let's fill in the boxes. What do you think would be the answer for the potential complication? Here we have pulmonary hypertension. This is the correct complication because this client with moderate obstructive sleep apnea, with AHI of 15 and poor CPAP adherence, he only uses about 4 hours every night. And he is experiencing exertional chest pressure and oxygen saturation of 90% on room air. That's a red flag. Now, whenever there is obstructive sleep apnea, whenever there is repeated apneic events, it can cause chronic intermittent hypoxia. Now, be careful because this will trigger pulmonary vasoconstriction. This will lead to increased resistance in the pulmonary arteries. And over time, this will raise the pulmonary arterial pressure. It will lead to pulmonary hypertension. And the strain on the right ventricle can lead to symptoms like chest discomfort. Whenever they're exerting, there's going to be difficulty of breathing, there is going to be mild hypoxia, and right-sided heart failure in the advanced stages. Now, let's look into the other options here that are incorrect. Why not acute MI? Well, it's kind of reasonable to think of this one because of the chest pressure. This can be cardiac, but the reason why it doesn't fit here because there's no mention of typical angina features. There's no reports about how the pain radiates, no sweating, no nausea. And the chest pressure that the patient reported is exertional. It seems to occur in the setting of low oxygen saturation, which is more consistent with right-sided heart strain. Also, when you look into the ECG, there are no lab results about troponins, which you'd expect if the provider suspected an MI. So we're going to eliminate that one. Now, if you selected hypothyroid crisis, that's also incorrect, because this condition is a severe and life-threatening form of hypothyroidism that includes altered mental status or coma. There can be hypothermia, bradycardia, respiratory depression, and these are triggered by infection, could be use of sedatives or cold exposure. But in this client, the laboratory did not say anything about TSH, and there is no evidence about cognitive decline, no bradycardia, no alteration in their temperature regulation. Now, if you selected major depressive episode, yes, the client has some issue with some moderate depression, but we have to ask here, does depression explain the chest pressure? Of course, no. And will it cause low saturation? No, either. So could it be worsened? Or will it worsen the sleep quality or the CPAP use? Of course, possibly, but it doesn't explain the acute physical findings the patient is reporting. And so for the depression, it can coexist, but it shouldn't be used to explain the new onset or worsening cardiopulmonary symptoms. So we need to rule out the physical causes first. Now, if you selected chronic kidney disease, this is common in patients with OSA or hypertension, but in our case scenario, it lacked about creatinine or BUN that are elevated. There are no electrolyte imbalances, and there are no signs of fluid overload or no anemia. So there's nothing in the case scenario pointing to worsening of the kidney function. So let's move on into the assessment findings. This time we have the options: creatinine 1.8 milligrams per deciliter. We have the PHQ of 9, score 12. We have the oxygen saturation of 90% on room air, a TSH 4.5 milliunits per liter, and chest pressure after exertion, and the blood pressure 165/100. The answers that you should select are the following: chest pressure after exertion, because this is a classic symptom of pulmonary hypertension, wherein the right ventricle has to pump against higher pulmonary pressures. And this strain becomes most obvious during physical activity. Again, only going to happen when there is exertion. This is not a sharp or positional pain, and there's no sign of myocardial ischemia. This is the kind of vague chest discomfort seen in pulmonary or right heart problems. Now, the other assessment findings should be saturation of 90% on room air. This is low. Normally, it should be 95% and above in healthy individuals. So this one suggests that the client is chronically hypoxic, even when he is awake. Again, pointing to pulmonary vascular disease from untreated obstructive sleep apnea. Now, why not TSH of 4.5 milliunits per liter? Well, this one is actually in the normal range. And so this rules out hypothyroidism as a cause of the symptoms. So remove this one. Now, let's look into a PHQ-9 score of 12. This one shows a moderate depressive symptoms, but it's not severe. We are going to be much more concerned if the score is equal to or greater than 20. And depression doesn't cause chest pain or hypoxia. And it might affect CPAP compliance, but it is not the root cause of the current physical symptoms. So, clinical tip for you here: we're going to address mental health, but don't let it distract you from a serious cardiopulmonary condition. Now, what about creatinine of 1.8 milligrams per deciliter? This is mildly elevated, but there's no context to say this is new or relevant. There's no fluid retention or uremia described. And it doesn't help us explain the chest pressure or the low saturation as well. So do not treat a single abnormal lab without clinical correlation, and this doesn't really help explain the client's symptoms. Now, for the interventions, the options are administer nitroglycerin stat, obtain order for renal function monitoring, refer for psychiatric evaluation, initiate levothyroxine therapy, notify the provider for urgent cardiology consult, and administer supplemental oxygen per protocol. Well, one of the correct answers here is to administer supplemental oxygen per protocol because our patient saturation is low in the 90s. This patient is on the edge of hypoxia. So the oxygen therapy will help improve the patient saturation. It will decrease pulmonary vasoconstriction and will reduce cardiac workload, especially on the right side of the heart. So the next intervention that you should pick here would be notify provider for urgent cardiology consult. This is critical because the symptoms suggest pulmonary hypertension, and this condition requires for follow-up diagnostic studies, could be echocardiogram, or it could be possibly the use of vasodilators or maybe advanced therapies. And there's also going to be a need for early cardiology involvement to help prevent this disorder to progress into a much worse condition, such as right side heart failure. So for this one, you need to escalate the care when the symptoms signal potential deterioration. So here, do not wait for more labs to worsen. Now, let's look into the incorrect interventions here. If you selected initiate levothyroxine therapy, well, go back into the data. The TSH is normal. Giving thyroid hormone in this person who has a normal TSH level is dangerous. It can lead to tachycardia. It can lead to anxiety, arrhythmias. It can also lead to bone loss over time. Now, if you selected refer for psychiatric evaluation, we know that mental health matters, but right now this patient has oxygen desaturation and chest pressure. These are the two priority problems that you should address this time. Yes, we are going to address the depression, but after we have stabilized the patient. Think first about ABCs, airway, breathing, and circulation before mental health referrals. Now, if you selected obtain order for renal function monitoring, well, nothing really is acute. This is not the time to focus on the kidneys when the client is a hypoxic or has exertional chest pressure, and if there's also no risk for cardiopulmonary deterioration, or well, the patient is at risk right now. And so your point here is to stay aligned with the most urgent system involved. Now, if you selected administered nitroglycerin stat, well, nitro is for coronary ischemia, and this can be harmful here. In pulmonary hypertension, when you are going to cause a drop in the preload too fast, this can lead to hypotension, can cause syncope. It can also decrease right-sided cardiac output. So do not use cardiac medications reflexively. You got to ask if they're going to match the costs. So eliminate that one. Now let's move on into our test item number 3.
Before moving ahead, I have some exciting news for you. If you are determined to pass the NCLEX within a week or a month, then your best option is to enroll in our complete online NCLEX review crash course right now. This course is a comprehensive all-in-one solution, a guaranteed shortcut, and a proven method to pass. Over the last 5 years, more than 5,000 students have successfully cleared their NCLEX exams using this course with an impressive 99% passing rate. Here's what you'll get: 100-hour animated mini crash course, ideal for those who have limited time and want to pass in just 1 week. 300-hour comprehensive recorded lectures covering 300 high-yield NCLEX topics that the exam loves to test. 5,000 real NCLEX questions, practice with actual past exam questions for better preparation. 15 full-length practice tests, including CAT simulation. Feel confident before your real exam day. Exclusive NCLEX eBook, the ultimate guide you need to pass. 1 year full access. Study anytime, anywhere at your own pace. This is a limited time offer. Enroll now to grab 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. All right, now let's dive into the topic.
So we have the same information about the nurse's progress notes. So the task here, it said, on day 14, the nurse prioritizes strategies to improve CPAP adherence. Select the most appropriate strategy and rationale for each barrier. We have barriers: massive discomfort, nasal congestion, claustrophobia concern. So we have rows for strategies and for the rationals. So in this test question, you need to start identifying the 3 reported barriers first that are associated with the CPAP use. Then ask yourself what practical nurse-driven interventions can reduce each barrier. And make sure that you match each barrier with a solution that is safe, that is evidence-based, and realistic for improving adherence. Now, you need to pay attention what the patient is experiencing here. Could be discomfort or could be anxiety. And then link that to a rationale that explains how the strategy helps. And of course, you need to eliminate any options that require prescription or address problems not mentioned in the case. So we have the strategy options and the rational options. So scan first. The choices here for strategy option, it said, teach nasal saline irrigation, recommend gradual CPAP desensitization, administer oral decongestants, switch to a full face mask, and adjust the mask fit with the sleep technician. For the rational options, we have reduces air leaks and pressure sores, builds tolerance to mask sensation, treats underlying sinus infection, improves comfort for mouth breathers, and clears nasal passages for airflow. Now let's fill in the blanks here for the first barrier. What do you think would be the strategy that you can use for mask discomfort? Well, the answer for that one is adjust the mask fit with a sleep technician. Why do you think this works? Well, this is a very hands-on patient-specific solution. When a CPAP mask is not fitted properly, it can cause all sorts of issues. It can lead to air leaks, maybe red marks on the patient's face. There's going to be sore spots and some general irritation. So whenever we are going to tap a sleep technician, they have the tools and the experience to customize the mask to the patient's face and shape and pressure settings. So for patients who say the mask is uncomfortable, this is one of the most direct and helpful fix. So again, the nurse here can educate and refer for the service, which is absolutely within the nurse's scope. And of course, the rationale here is to reduce air leaks. It will also reduce the pressure source. Let's look into the second barrier for nasal congestion. What do you think would be the answer here? That would be teach nasal saline irrigation, and this is going to clear nasal passages for airflow. So when a patient says they feel stuffy or blocked when they use a CPAP, so they might eventually stop using the CPAP altogether. And that's where saline nasal rinses will come in. So these nasal rinses will actually be easy for them to do. It's safe, it's low cost, and this procedure will help clear out the mucus and allergens. It will also improve the airflow through the nose, and particularly helpful for patients using a nasal or nasal pillow CPAP type of mask. Now, this is something nurses can show or explain during a visit, and there's no prescription required for this one. And it gives patients a sense of control over the issue. So let's look into the third barrier, claustrophobia concerns. What do you think would be the strategy here? The answer is recommend gradual CPAP desensitization to build tolerance to mask sensation. So this one is all about behavioral adaptation for someone who feels panicked or anxious when they're wearing the mask on. So they definitely need to do this whenever there is like some kind of resistance. So gradual desensitization means introducing the mask in small steps, like wearing it while watching TV, or they're relaxing during the day without pressure initially. And this technique comes from behavioral therapy principles, and it's also shown to have strong evidence for increasing comfort and tolerance. This one is safe, it's nurse teachable, and most importantly, it works with the patient's fears, not against them. Now, if you selected the other options, let's say administer oral decongestants, what do you think about this one? Yeah, nasal decongestants is a real a treatment, right? This is something that can relieve nasal congestion. But most of these medications have pseudoephedrine, or let's say phenylephrine, which can cause serious effects, especially for the older adults. They already have hypertension, and we know that these medications can raise their blood pressure, and our patient is already hypertensive. It can lead to insomnia, increase their heart rate. Again, this could be dangerous in a patient that is already dealing with sleep apnea or cardiovascular risk. And also, nurses don't really prescribe these. We need to make sure that the healthcare provider is aware about what's going on. All right? We just cannot recommend over-the-counter medications without the provider's awareness. Now, if you selected switch to a full face mask, this is also incorrect. Well, you might think that this might seem like a fix, especially if the patient is having nasal issues, but a full face mask is larger. This is bulkier. And for someone who's already struggling with claustrophobia, this could actually make things worse. And it also doesn't really fix the issue of mask discomfort. So if the fit is poor with a smaller mask, and if you're switching to a larger one, it doesn't really solve the root problem. So this strategy might just backfire for both the mask discomfort and claustrophobia. So eliminate this one. And if you selected treats underlying sinus infection, do we have that? Yeah, this is incorrect, because there's no mention of patient having signs of a sinus infection, no facial pain, no reports of fever, no thick drainage or diagnostic tests about that, just nasal congestion. It's quite a stretch to assume there's an infection here, and doing so will lead to inappropriate treatment. So do not pick this one. Another option that is incorrect: improves comfort for mouth breathers. Well, this would only apply if we knew the patient was a mouth breather, but the question does not tell us that. And if you make assumptions not supported by the scenario, this is a common test-taking trap. Plus, switching to a full face mask for someone who's not a mouth breather could add bulk and discomfort for no reason, especially harmful if claustrophobia is already an issue. So here in this test question, when you are choosing strategies on NCLEX-style items, stick strictly to the data given in the scenario. Do not add information or make assumptions, and ask, is this something a nurse can do or teach? And make sure that you're going to prioritize patient-centered solutions that will improve the patient's comfort, their safety, and adherence. Let's go into the next item. We have here the same nurse's progress notes. It said here, on day 15, the nurse evaluates the urgent care presentation to assess obstructive sleep apnea's impact on cardiovascular health, indicate whether each finding suggests a direct obstructive sleep apnea effect, treatment-related issue, or unrelated condition. So we have our matrix here, and the corresponding findings: blood pressure 165/100, dyspnea on exertion, nasal congestion, trace ankle edema, A1C of 6.3, morning headaches, heart rate of 90 beats per minute. Patient reports mask-related claustrophobia. So here, you need to review each clinical finding from day 15 and think, is this a direct result of obstructive sleep apnea? Is this a side effect of CPAP therapy? Or is this something untreated or unrelated, I should say? And make sure that your understanding of the obstructive sleep apnea pathophysiology is utilized, especially how chronic the hypoxemia affects the heart and the lungs, so to help your judgment here. Now, I want you to think about what symptoms are commonly caused by CPAP use, like airway irritation or anxiety, and also avoid double categorizing and stick to the most likely source of each finding. Now, what do you think about the high blood pressure of 165, 100 mmHg? This is a direct obstructive sleep apnea effect because OSA can lead to intermittent hypoxia. It can cause frequent arousals during sleep, which can stimulate the sympathetic nervous system. And this repeated activation can cause the blood vessels to constrict. It can cause the heart rate to go up, eventually resulting in sustained hypertension even during the daytime. And the patient that we have has a high hypertension history, and it's going to make that even worse. And that's why we are selecting this one. Now, why not treatment-related issue or unrelated condition? Well, it's because CPAP can actually reduce blood pressure when used consistently. It's not a side effect of the therapy. And of course, this is not unrelated condition because hypertension is one of the most well-established complications of untreated obstructive sleep apnea. So it's not unrelated. Let's move on to the next finding, dyspnea on exertion. What do you think about this one? Well, this is direct obstructive sleep apnea effect because whenever there is chronic intermittent hypoxia, which can lead to pulmonary hypertension, especially when the oxygen saturation is borderline, or let's say around 90%, and this one can overload the right side of the heart, which struggles to pump the blood effectively to the lungs, and eventually results in shortness of breath during physical activity. Now, why this is not treatment-related issue? Well, because CPAP can help prevent this complication, and if a patient is still breathless, it's likely due to ongoing disease, not about the treatment. And why is it not unrelated condition? Well, if we are going to ignore this as unrelated, we are going to risk missing progression to a right-sided heart failure, which is a key obstructive sleep apnea complication. So, not unrelated. Let's move on into nasal congestion. What do you think about this one? This is associated with treatment-related issue because CPAP machines blow the pressurized air into the airway. This can dry out or irritate the nasal passages, and this can cause congestion, runny nose, even inflammation. And this is one of the most common reasons patients struggle with being compliant in wearing the CPAP. Now, why not direct obstructive sleep apnea effect? That's because obstructive sleep apnea causes apneas and hypoxemia, not nasal inflammation. So this one is purely a result of how CPAP is delivered. It's also not unrelated. So if we're going to call it unrelated, we ignore a fixable barrier to treatment adherence. So that's why we're not going to check that box. Let's move on to trace ankle edema. This one is a direct obstructive sleep apnea effect because whenever the person has chronic obstructive sleep apnea, it can lead to intermittent hypoxia, can cause pulmonary hypertension, and eventually right-sided heart strain. So this is going to lead to venous congestion and mild lower extremity edema. Even trace edema can be an early red flag here. Now, why not treatment-related issue? Well, it's because CPAP is not the cause here. CPAP actually can help prevent this downstream complication. It's also not unrelated condition because the trace ankle edema is well recognized as cardiovascular complication of poorly managed obstructive sleep apnea. Now let's look into A1C 6.3%. This one is categorized as unrelated condition because an A1C of 6.3 shows prediabetes, which may be linked to the patient's obesity, which is a shared risk factor for both obstructive sleep apnea and metabolic syndrome, but it's not directly caused by obstructive sleep apnea, and that also directly caused by the CPAP. So this one is a separate comorbidity that should be managed individually. Now let's look into the morning headaches. What do you think about that one? Well, this is a direct obstructive sleep apnea effect because OSA causes poor nighttime oxygenation and sometimes buildup of carbon dioxide, or what we call as hypercapnia. And these shifts can trigger vasodilation in the brain. It will cause morning headaches, especially common when the apnea-hypopnea index is still elevated despite treatment. Now, why not? This is a treatment-related issue. Well, it's because CPAP, again, is designed to prevent apneic events. So this is supposed to reduce those headaches. It's also not unrelated condition because headaches that consistently happen on waking are classic signs of unresolved obstructive sleep apnea. Now, we have heart rate of 90 beats per minute. What do you think about this one? This is direct obstructive sleep apnea, effect because a resting heart rate of 90, especially when a baseline was 80, this one indicates increased sympathetic tone, which is a hallmark of obstructive sleep apnea. I should say poorly controlled obstructive sleep apnea. And here, the body keeps thinking it's under stress due to the repeated oxygen drops at nighttime. So this will lead to a persistently high heart rate. And lastly, we have patient reports mask-related claustrophobia. Obviously, this is associated with treatment-related issue because CPAP masks can feel confining, especially those full face masks, and this sensation can provoke anxiety to the patient, can cause some panic, even resistance to being compliant to the therapy. So this is a psychological barrier, not a physiological symptom of the obstructive sleep apnea. And this one is not a direct obstructive sleep apnea effect because OSA doesn't cause claustrophobia. The mask does. And this one is not unrelated condition either.
Before moving ahead, here's something you need to hear if you're feeling anxious about passing the NCLEX, especially if you're aiming to do it in 1 week or 1 month, then our complete online NCLEX review crash course is your answer. This is your shortcut to success, a tried and tested course with a 99% passing rate. More than 5,000 students have achieved their NCLEX goals using this course, and now it's your turn. Here's what's included. 100-hour animated mini crash course, perfect for last-minute preparation to pass in just 1 week. 300-hour comprehensive lectures covering 300 high-yield topics that the NCLEX loves to test. 5,000 real NCLEX questions. Train with real exam-style questions and be prepared for anything. 15 full-length practice tests, including CAT simulation. Build your confidence with realistic exam experiences. Exclusive NCLEX eBook and 1-year access. Study whenever you need without restrictions. Don't let this opportunity slip away. Enroll now at 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. Now, let's jump into the topic.
Because this is one of the top reasons for poor CPAP compliance. So it's definitely related to treatment. All right, this time let's move on into our next test item, number 5. This is on day 7, wherein the nurse reviews the polysomnography report and clinical notes for a 74-year-old male with suspected obstructive sleep apnea. Your task this time is to highlight the findings that directly confirm the severe obstructive sleep apnea in the context of the patient's presentation. Only select findings that specifically quantify or characterize the severity of obstructive sleep apnea's diagnostic criteria or physiological impact during sleep. So here is the polysomnography result. Let's scan the report. It said, polysomnography results show an apnea-hypopnea index of 40 events per hour, with 85% of events classified as obstructive apneas and 15% as hypopneas. Oxygen saturation nadirs at 82% during apneas, with an average saturation of 90% across the study. Sleep efficiency is reduced to 70% with 30 arousals per hour, primarily linked to respiratory events. The patient reports morning headaches and persistent daytime fatigue. His wife notes ongoing loud snoring and occasional gasping, though less frequent than baseline. The patient's BMI is 38.1 and neck circumference is 18 inches. Fasting glucose is 112 milligrams per deciliter and total cholesterol is 230 milligrams per deciliter. The ECG shows an S for gallop and blood pressure is 152/96. The patient reports difficulty adjusting to CPAP due to claustrophobia. Now, how are you going to answer this question? Well, I want you to not get distracted by supportive or non-specific symptoms. I want you to focus on what confirms the diagnosis and severity. So you only highlight the findings that meet formal definitions or thresholds tied to sleep apnea. So here we go. We have the first phrase that you need to highlight, and one of those is apnea-hypopnea index of 40 events per hour. This is the most critical diagnostic marker because this tells us how many times per hour the patient stops breathing, which is the apnea, or has significantly reduced airflow, the hypopnea. Now, according to standard obstructive sleep apnea classification, there's levels, right? One of the level here is mild obstructive sleep apnea, and the value should be a range of 5 to 14. Now, one is considered to have moderate OSA if the value is between 15 and 29, and severe OSA if the value is equal or greater than 30. So, with an AHI of 40, this patient clearly falls into the severe category, and this value reflects the frequency and intensity of the apneic events, and it's very central to his diagnosis. Another section that you should highlight here would be 85% of events classified as obstructive apneas. This one helps confirm obstructive sleep apnea, not central or mixed type. And take note that obstructive apneas occur when throat muscles intermittently relax and block the airway despite respiratory effort. And the predominance of obstructive events rules out other causes and also solidifies that this is obstructive sleep apnea and it is not a neurological or central respiratory issue. Let's move on here. The next phrase that you should highlight is oxygen saturation nadirs at 82% during apneas. Now, when you encounter the word nadir, that simply means the lowest point of the oxygen saturation level. It's actually dropping during the sleep. Now, it said nadir below 90%. It is concerning, right? Especially that it said 82%. It reflects significant desaturation, which means the body's not getting enough oxygen during these apneic episodes. And this is a hallmark of OSA severity. And take note that the more severe the OSA, the deeper and more frequent the drops in their oxygen levels. Now let's move on here. The next phrase should be 30 arousals per hour, primarily linked to respiratory events. So these arousals are brief awakenings caused by apneic events, especially the brain is jolted awake to restart breathing. And the 30 arousals per hour is very high, and it indicates disrupted sleep. And this is a very common occurrence in severe OSA. Now, this level of sleep fragmentation also contributes to the daytime fatigue. There is poor concentration and impaired quality of life. So that's all for the highlights. Now let's talk about the non-highlighted items here. If you selected average saturation of 90%, we know that this is borderline low. This is just an average over the whole night. So it doesn't really show how bad things get during the worst episodes. And the oxygenator levels are much more useful because they show how deeply oxygen drops. And this is going to be directly, it's going to correlate more with the apnea severity. Now, if you selected sleep efficiency is reduced to 70%, what do you think about this one? Well, sleep efficiency measures the ratio of sleep, the time of sleep versus the time in bed. And the value of 70% is reduced. Normally, it should be equal or greater than 85%. But this is not specific to obstructive sleep apnea, because many things can lower sleep efficiency. It could be insomnia, it could be pain, it could be anxiety or other disorders. While it suggests disturbed sleep, it doesn't really confirm why sleep is disturbed. Now, if you selected morning headaches and persistent daytime fatigue, well, these are common complaints among obstructive sleep apnea patients, but they are not specific. Many other conditions could be migraines, sleep deprivation, or could be anemia or depression can cause these symptoms as well. And again, not going to pick on this one. Now, if you selected loud snoring and occasional gasping, these are clinical signs of OSA and often prompt sleep testing. But again, these are subjective, not quantifiable. And some people snore without apneas, and gasping can be misreported or occasional. And these suggest risk, but don't really meet diagnostic criteria for severity. And if you selected BMI is 38.1, these are, and also the circumference of the neck, which is 18. Right. So these are strong risk factors for obstructive sleep apnea. Whenever there is a high BMI and large neck, this can indicate excess soft tissue that will narrow the airway, but they don't measure disease severity. These two will simply tell us who is more likely to develop obstructive sleep apnea. It's not really quantifying here. Now, if you selected fasting glucose 112 milligrams per deciliter and total cholesterol of 230 milligrams per deciliter, these values reflect metabolic dysfunction related to prediabetes, or it could be dyslipidemia, which are common in patients with obesity and obstructive sleep apnea. But these are not sleep study findings and also do not correlate directly with how bad the obstructive sleep apnea is. And the same thing with the ECG showing an S4 gallop. These are cardiovascular findings, not really gonna support the sleep study. The same thing with difficulty adjusting to CPAP due to claustrophobia. This only reflects a treatment-related barrier, not the disease itself. Alrighty, let's move on into our next test item, number 6. It said, on day 14, the nurse develops a plan to optimize long-term obstructive sleep apnea management. And the task is to select the 3 most critical nursing interventions to address challenges and promote sustained improvement. We have the options: collaborate with pulmonology to trial a mandibular advancement device, teach energy conservation techniques to manage fatigue, coordinate with a nutritionist to develop a low-calorie meal plan, administer a beta blocker to control hypertension, schedule weekly CPAP adherence telehealth checks, refer to a smoking cessation program, and educate the patient on recognizing pulmonary hypertension symptoms. So here in this item, I want you to identify the major ongoing issues, or let's say worsening of the symptoms, and make sure that you select the 3 interventions that are nursing-led, supported by evidence, and are designed to support long-term control of the obstructive sleep apnea. And think about what the nurse can directly influence. Could be through education or care coordination or follow-up, and make sure that you avoid selecting provided only actions or interventions unrelated to the patient's current barriers. So what do you think would be one of the answers here? One of these is coordinate with nutritionists to develop a low-calorie meal plan. This is a high priority, also a long-term intervention that directly addresses a root cause of obstructive sleep apnea and obesity. And the patient has a BMI of 38.1 kilograms, which is going to significantly increase their upper airway narrowing, especially during their sleep. And this one really matters because weight loss has been shown to reduce the apnea-hypopnea index. It can improve their oxygenation. It will lessen the need for CPAP in some cases. And this is also something that the nurse can coordinate with interprofessional care, including referrals with a dietitian, of course, and nutritionist. Another is schedule weekly CPAP adherence telehealth checks. Because the patient is partially adherent to CPAP, he said that he used only about 4 hours each night, even with apnea, hypopnea still at 15. So this one undermines treatment effectiveness. And why do you think this matters? Well, it's because the CPAP must be used consistently, usually more than 6 hours every night to be effective. And barriers like mass discomfort or claustrophobia can also cause poor adherence. And make sure that there is that telehealth checks, which will allow nurses to provide education, also to reinforce proper usage, and also to assess for the equipment issues. And this will eventually improve the patient's compliance to wear the mask. Now, another answer here is to educate the patient on recognizing pulmonary hypertension symptoms. Why? Well, the patient is showing signs of possible pulmonary hypertension. They are developing dyspnea. There is chest pressure. And whenever there is untreated sleep apnea, this can lead to pulmonary hypertension due to the chronic hypoxemia and elevation of the pulmonary artery pressures. And this one really matters because early identification of pulmonary hypertension symptoms can lead to timely evaluation and treatment. And nurses are key in patient education and monitoring of the symptoms, especially for high-risk complications. Now, the other options are incorrect. If you selected collaborate with pulmonology to trial a mandibular advancement device, this is valid alternative to CPAP, but this is only reserved for mild to moderate obstructive sleep apnea or when the CPAP is contraindicated. And in this case, CPAP is already in use and a bit partially adhered to, and it remains the first line therapy for moderate severe OSA. And in addition to that, initiating a MAD trial or a mandibular advancement device, it also requires specialist assessment. It requires prescription, which is beyond our nursing scope. Now, if you selected teach energy conservation techniques to manage fatigue, this is incorrect because fatigue is already a common symptom in OSA, but managing fatigue without correcting the underlying cause is like treating the smoke instead of the fire. So eliminate this one. Now, if you selected administer a beta blocker to control hypertension, this is outside our nursing scope unless it is ordered by the medical provider. Also, while hypertension is a common comorbidity in obstructive sleep apnea, treating it doesn't directly treat the obstructive sleep apnea. That's why this is not one of the priority options. Now, if you selected refer to a smoking cessation program, we know that smoking is a risk factor for obstructive sleep apnea, but in this case, the patient quit smoking 10 years ago, so this is irrelevant. There's no indication that smoking is currently contributing to the patient's symptoms. Now, I want you to remember, especially in the NCLEX, when you are managing obstructive sleep apnea, our role goes beyond recognizing the symptoms. It's about identifying complications, supporting the treatment adherence, and also using nursing-led strategies to prevent long-term harm. So if you find this review session helpful, do not forget to subscribe to the YouTube channel for more NCLEX prep, and give this video a thumbs up and share it with your study buddies. Thank you for watching. I'll see you in our next review session.